we continued, since in the clinical application these oligonucleotides were not very good applicable, we continued and we started very early with so-called small interfering RNA. These are small 21 nucleotide double-stranded RNA molecules which are given to the cells, and then they form the so-called RNA-induced silencing complex. So actually the same principle, that finally the messenger RNA which is targeted of our complement regulators are cleaved, and there is a reduced expression of these molecules. And indeed this was the case. Here you see again the expression of these three regulators in two different cells, tumor cells, prostate, and breast carcinoma cells, and for CD46, 55, and 59 in both cell types, we got a nice significant reduction of this expression of these regulators. So did it have a consequence? Yes, it had. If we individually silence down the regulators by themselves, and especially again if we use the combination of these sRNAs against all three regulators in both tumor cells, we got a highly significant induction of lysis, so the resistance was almost gone in these tumor cells. So if I summarize to this point, besides all these mechanisms of immune escapes of tumors, and you have all learned this during your career time, low immunogenicity for different factors, antigen degradation, immune suppression. There are so many different immune response, escape mechanisms by tumor cells. But now we also know exactly, and also the molecular background, that indeed there's also complement resistance of these tumor cells. So the question arises, how can we cope with this? I have shown you some good examples, but those who are more familiar with complement, they will now ask the question, if you now treat a patient with such an sRNA, which is already done in the clinic, not in this system, but against some oncogens, what happens to the tissue, to the normal tissue? Because we all need these regulators on our tissue to prevent a severe inflammation. The only solution is we have to target it. How can we target these molecules to the tumor cell? So what we now are doing since 1 or 2 years, we generate so-called liposomes, mini particles, in which we include our sRNA, and so like against these complement regulators, and then we add to the, we integrate into the surface of these liposomes tumor-specific antibodies. And in addition to liposomes, we have other so-called lipoplex structures which bind the sRNA on the outer surface, and then we target the tumor cell. And these are the first results, and it's still ongoing research. Here we have we used Herceptin. This is the antibody which is given in the clinic to breast cancer patients, into the surface of the liposomes, and we integrated fluorescein showing, and then later also this sRNA. And what you can see in the breast cancer cell, we get a nice binding, whereas in the control cell there's no binding. But if we look more sensitive in cytopherometric analysis, we found that also to the control cells there are a few of these liposomes were binding. And this is not very surprising, because these liposomes, they have a charge of the lipids, and these lipids bind to every tissue. So this is a very important thing which we have to consider in the further generation, the composition of the lipids in our liposomes. But what we found here, after doing this experiment, we also got a very nice down-regulation, knockout or knockdown of these complement regulators. Here's an example of CD59. But also a little, also significant down-regulation in the control cell, which we cannot allow. So our future research in this field, and we have now very good results, maybe I can present it next time, is that by changing the charge of these liposomes, that we can get rid or at least reduce significantly the unspecific binding. And Of course, you will ask, does it have any effect? Yes, it had. We could increase significantly the rises of these tumor cells. So if I conclude now, we have learned complement resistance impairs the antibody-based immunotherapy of cancer, and this is a very important issue nowadays. The inhibition of membrane complement regulators either by tumor targeting by specific antibodies or what I now told in the last minute, the targeted knockdown of membrane complement regulators on the tumor cell may promote, I hope, the antibody-based tumor immunotherapy. So this research was done actually in 2 cities of the world. This is the city of Heidelberg, the old part. It's a very small city, just 140,000 inhabitants, but 35,000 students. So it's a really academic city. It has a German Cancer Center, it has the European Molecular Biology Laboratory, it has some other scientific institution. It's the current center of biomedical research in Germany. And this is Tel Aviv in Israel. My colleague is living there and he is doing research here. And these are the people involved in these studies. These were all my doctoral and postdoctoral fellows. And we were supported by different means. And this is a group of Sim Fischelson, my colleague in Israel. And we also have a collaboration with our partner university in Wuhan, the Tongji Medical University, with Professor Li as well. And thank you very much for your attention.
That the complement resistance associated antibodies. And as you mentioned, there are 3 classical pathways, the alternative pathway and the 3 cascades for the complement, the classical one and the alternative one. And we know that antibodies is associated with the classical pathway. What about the other 2 pathways, the alternative pathway, which is could be divided as a part of the innate immune response, and we know that innate immune response is the first arm of defense mechanism, and at the same time the presence or the absence of the regulators themselves are a sign of protection, i.e. when those regulators are absent or present, they give a signal to the complement themselves to do lysis. Thank you very much.
Okay, you touch a very interesting question. Indeed, we looked, and others did as well, if tumor cells are able also to activate the alternative pathway and the lectin pathway. Actually, this is not, there are very, very few examples, at least from experiments, indicating that only very few tumors, and maybe only in certain situations, are able to activate the alternative pathway. Now, there have been recently reports that certain tumor cells with high load of carbohydrates on the surface may bind the mannose binding lectin, and inducing the lectin pathway. This has not been investigated in more detail, but this may be offering a new possibility. But nevertheless, it doesn't depend on the pathway of activation. The complement needs tumor cells which have an overexpression of regulatory proteins. And only if these regulatory proteins, and of course also the synthesis of soluble inhibitors, are prevented or turned down, then complement has a chance to kill the tumor cells. And the particular importance nowadays is that many clinicians and patients have a great hope and rely on the action of specific anti-tumor antibodies. And one of the major effector mechanisms is the activation of complement, we know from other treatment options. But if this major effector mechanism, which usually kills everything, is not able to kill tumor cells, then much of the biological activities of these very highly valuable anti-tumor antibodies cannot be induced. So we have to work on this.
I have a question. Can you understand what would be the mechanism here? Isn't that paradox? You would reduce the C95.
Destroy the cells. They will destroy a normal cell. So
why then not destroying them?
Because the cascade reaction is blocked, cannot continue. If there is an activation for the first steps, and then it's stopped by either the 3 activation or latest by the induction of membrane complex. So, so we have no effect on this complement activation.
You always like to hear my voice loud.
Exactly.
I thank Professor from Germany for his presentation, which is very important, specifically for developed and developing countries. You see, growing countries and developed countries, because we are suffering in Sudan and worldwide from environmental pollution, which are rising, suffering from tumor, as you know, as it is. So I think this is very important topic to be highlighted in this conference, and we have to think about how to gain more applied researches towards this topic and how to put models on new drug design delivery systems to treat and to upgrade the other treatment running for tumor. Thank you very much.
Which we may not see in Germany, and we may have some other tools to let's say, to cope with these tumors. And so I can really only highly recommend that you all seek the collaboration. Internationally, we are a global work, and it should not be just a name, it should also be put life into this, so that you should go to international meetings, you should discuss it with your international collaborators, potential collaborators, and only by this we can try to the benefit of the patient.
Professor Michael Wally. It's a pleasure, in fact, to have with us Professor Mikhail Keshev. He's one of the prominent professors really globally, especially in immunology and particularly at the EDC, Faculty of Medicine, starting from 1:30. All are invited. Thank you so much.
In general, but in particular cytokines by the tumor cell, that in their autocrine reaction, they will also reversely act on the tumor cell in increasing the resistance to complement. And what is also interesting, what we learned is, I didn't show the data here because we are still working to finish it, is that tumor cells are able to produce a soluble regulator in addition to the membrane regulators, which autocrinely rebinds to the tumor cell and even increases the resistance more, so that not only 3 regulators on the surface, now they are sitting 4 on the surface. But I think more importantly is what you mentioned is we do not really know about the autocrine action of tumors and what they do, and because we do not know sufficient enough about the so-called microenvironment, because what we measure in the patient at least is usually either by biopsies, so histologically, or in the bloodstream. But this by far does not really reflect what is going on in the microenvironment of the tumor. And this, I think, the fate, the development of the tumor very much depends on all these factors, pro-tumor, anti-tumor factors, which are either given by the surrounding tissue or in an autocrine fashion by the tumor cell itself. Thank you very much. Just one last comment to the long way. Everything in life is relative. If I go by train from the north to the south in Germany, it takes me more than 6 hours, and it takes me only 6 hours to fly from Frankfurt to Khartoum.
The Dean of Faculty of Medical Laboratory Sciences, University of Khartoum, the Dean and Governors of this beautiful place, Education Development Center. It's my pleasure on their behalf, on behalf, welcome you, Mr. Michel. I know it's very difficult. Michel or Mikhail or Michael. Michel, you use it, Michel. The University of Khartoum has started a good program, generous supported visiting professors. And Sunday batch 6, every 6 visiting professors this year. And one of those is the distinguished Professor Gershwin, who is a professor of immunology. Those of you who attended his lectures the last week must by now have become experts in those who didn't, he's taking another option this time, which is in medical education. He comes from the University of Heidelberg, the oldest university in Europe. How many years?
625.
625 years is the age of their university. So obviously they can talk about the progress in medical education and all education. And he will tell us his experience. He's got 2 topics. One of those is development of new curricula for medical colleges. And the other is problem-based learning. The arrangement of these 2 topics in succession is based on your, both topics are important, but it is the convenience which has set the curricula taught first. All can attend it. For those who can bear with him, the more demanding lecture on problem-based learning. So he will take the one on the development curriculum first, and then the second one on problem-based learning. Most welcome, Professor.
Thank you very much for this kind invitation to give me the opportunity to tell about our development of our new medical curriculum in Heidelberg. The second talk was more considered to be a seminar. And this is on PBL. PBL is a method. And usually you should start with the philosophy and later you continue with the application. And so I think it's natural to start with the curriculum development, and only one element of this is PBL. I've talked to many of you who are responsible for teaching in different faculties, and I was very much impressed also by seeing some facilities at the Soba Hospital belonging to the medical education part, how far you advanced in establishing even buildings which provided opportunity to do modern medical teaching, like what we consider very important for examination but also for training is the OSCE, the Objective Skilled Clinical Examination. And on the same side, but at the same time, there's also a program being developed on so-called e-learning. E-learning is a magic word, and we should not shift our traditional training of the students face by face and by the book entirely to e-learning, but it may be a very good support. And then another issue is problem-based learning, and I've heard that it's also already realized. So actually, in certain regard, we have a word saying in Europe, don't carry owls to Athens. This is an old saying, meaning in Athens, the capital of Greece, they have many birds, many owls. So you should never carry owls to Athens because you have enough owls. So it may be that many things which I'm talking to you have already developed. I had no time before to get enough information to see what is the current status here. And maybe you'll just follow me how we did it over the period of the last 12 years to develop our curriculum. Usually the politicians like this, and you have to coin a name or a short form. So since the Europeans, and especially also beyond Europe, of course, in medicine, the Latin language is still in fashion, we call it Heidelberg Curriculum Medicinalis. So the curriculum in Heidelberg, and maybe now this slide, now it's difficult to see here. So HaiQMed. So this is now in the website HaiQMed, everybody in German knows it. So how did we start? And actually we started, as you usually do if you develop new programs, you have a mission, you know what you want, or at least you have a kind of idea you want, and usually you sit together with a group of responsible people, decision makers, and you say, what do we want to introduce? And this is based, of course, on the change of the society, the increasing amount of information we get in medical science. This applies also to other faculties, of course. So we have first on the faculty level, we have what we call mission. Yeah, we have the definition, what do we want to do? And this translates very later to the learning objectives. We have to consider on the course level, what should be the content? Are these the same contents like we used to have in the last 20 years? Or do we need to adapt the content in all individual subjects? And then how do we assess it? There's nothing worse of this entire system if you do not have an assessment which returns back to you the information if everything you did is right. So this is a picture which we use when we go abroad and talk to our colleagues in foreign countries. And the development was like this, that we first did it in Heidelberg. We had some counseling from our colleagues in the Harvard Medical School and from other in Europe as well. And then later, when we had established and saw that there were certain success with our program, we were asked by other faculties in Europe and nowadays also in China if we could give them some advices, some counseling, if we could introduce some courses on this. And we usually say, there's a train is a train on the first view, but they have different tasks. If you take a train in Switzerland, it needs to be differently equipped than a high-speed train in a flat area of China. So this means you have to adapt your ideas to the situation in the country, to the situation in the faculty you are going to deal with. So what are the main columns which are built up, on which you build up a possible change? And if we start thinking in this direction, we should also consider that it should not be a change just for the next 2 years, but it should be probably have a future, it should be sustainable. So we have on the one side we have the people, and most often, and actually every time the people are more important, but we also have the content. So we have first to think, how do we change minds? Do we all agree in a change? Do we actually need a change? So we need to have a concept. We have to have a consensus on this. We need to agree on this. Then, like all works, we need again another committee, a committee of very knowledgeable people which communicates, and we have to set up a network because it should not stay in the group which is developing it, but it should spread from the very beginning to all places in your faculty. And I say it already now, in this network there should be included the dean, of course, the professors who run the chairs of the different institutions, and the lecturers, at least some representatives, and last but not least also the students. You have to listen to the students' opinion. The curriculum development which actually comes if you once have established this has to do with the content, but not only on the content, you also have to think about how do the students, especially the medical students, get their skills. And equally important, the particular attitude. You have to have a certain attitude as a medical doctor, which is very different from somebody who is an engineer or somebody who is doing chemistry or something like that. Their attitudes count very much in the teaching and the development of the medical field. You have to set up finally a kind of culture of teaching. Culture of teaching means that those who do teach feel committed to teaching. I know and actually there's no difference in all countries which I have visited, is that there are some professors and lectures probably not so much because it's their paid business, but chairs of institutions who are actually obliged to teach, they don't like to teach because it takes away the time for research. So you get much more credit for your research, for your international papers, than for doing teaching to the students. So this is very important that we will develop a kind of culture of teaching and learning, of course. So if we have this cycle starting from problem definition, needs assessment of targeted learners, learning objectives, educational strategies, implementation, feedback, and this circle goes on and goes on, then, as I mentioned before, the first question is why a change? Do we need a change at all? And if I go back to the time when we started to think about this, we had a great resistance in our faculty council. I say unfortunately on the one side, on the other side of course it's very fortunate. The Heidelberg Medical School is the best in Germany. Our ranks all time between place 1 and 2, competing with Munich. And our students, they do a very excellent examination. So the professors in the council who didn't like a change, they said, why a change? Because we are the best. Can we get better as being the best? So it was very difficult to convince them that even if we consider to be very good, that there's all the time a need for a change to compete, let's say, even with other international universities. And I think if it comes to the term competition, and probably on an international base to be a little bit better, then maybe some of those who are resistant, they start to agree. So who is involved? You have to find the right person. What do they, the faculty, the students, and the others, so on different levels, what do they need for this change? So how do we define the learning objectives and what competences should? Competences is much more than just the knowledge, so it's a combination of everything. So what competences should these students of the year, for example, 2015 or 17, who now start, should have? And how do you provide the information, how do you provide the teaching to achieve these competencies? And once you have done this theoretical framework, how do you implement it? This is a very difficult step. What are the strengths and the weaknesses at the moment of our current curriculum? This is a kind of assessment you have to do. What support and what resistances do you expect? This needs to be clarified before you introduce the curriculum. And then, of course, you have to think, how can I make sure that everything which I now introduce is a lot of work, and including many people, how can we assess that it's really getting better, that it's meeting our needs, and what's successful, what was not successful. And actually, this circle starts over again. After we have established in, and we do an evaluation after 1 year or 2 years, we have to start over again. So now some basic information for you. In Germany, we have a 6 years curriculum, 2 years of preclinical studies, then the first so-called state exam, so all students have at the same time, with the same questions or examination, an examination after the preclinics, and then those who survive, they continue on the 4 years clinical study, and then they have the second quite large state exam, which is not only a written examination, also written oral and a practical application. The number of students is per year 280. Actually, this is an old number of 5 years ago. Now we have 350 per year, which is, we are coming to the critical situation to handle it with this new program. And in dental medicine we have another 81 students. So times 6, you can calculate how many students we do have in the job. So if I go back a little bit in history, the development, so in 86 we had 600 years, now we have 625 years. And actually from the beginning there was a medical chair, and 100 years later the second.